This is Dr. Chad Rappaport. This lecture is on insertional Achilles tendinopathy. I have no personal disclosures. We're going to touch on and review the etiology, the pathogenesis and pathomechanics, the physical exam, imaging, non-operative treatment, operative treatment, and complications. Insertional Achilles tendinopathy is a degenerative enthesopathy involving the distal Achilles and the calcaneus. It is largely a tendinosis or degenerative condition, although there have been studies that suggest that there are inflammatory cells at the interface between the Achilles and the calcaneus, indicative of a tendinitis. This typically occurs in two subsets of patients: younger, more active patients, typically runners and athletes. These patients tend to present with less degenerative changes and are easier to treat than their counterparts who are typically older, heavier, and more sedentary. Almost pathognomonic to the condition is a posterior heel spur. Patients can present with several different complaints of pain and stiffness with startup and/or pain or stiffness with prolonged activity. Many patients, particularly females, in whom this disease process is more predominant, complain of pain with shoe gear, and ultimately this can interfere with their ability to work and enjoy their personal life. This is something that is difficult to treat non-operatively the more chronic the case is. This is a condition that involves bone, tendon, and bursal tissue. The bone portion of the condition resides in the painful prominent posterior osteophyte, as well as within the so-called Haglund's deformity or bursal projection of the heel, which is pictured here. This can cause damage to the anterior margin or aspect of the calcaneus in dorsiflexion. It can catpaw, if you will, at the tendon, causing initially inflammation, inflammatory changes, and pain, and ultimately more degenerative conditions and issues. Of course, the tendon is at the forefront of this diagnosis, with degenerative changes within the tendon that can be seen on MRI, which we'll talk about momentarily. Patients often, because of a lack of real estate due to the enlarged Haglund's deformity or bursal projection, can develop inflammation or squeezing or irritation of the retrocalcaneal bursa, consistent with retrocalcaneal bursitis. There has been some loose ties from an etiological standpoint to patients who have hypertension and diabetes, but I think at the heart of the pathogenesis of this condition is biomechanical and stress-related changes. With specific regards to the Achilles, we certainly see degenerative changes for the most part within the Achilles, with some occasional signs of inflammatory changes. There is loss of the organization of the collagen at its insertion, with a subsequent loss of elasticity, particularly as the calcific posterior osteophyte progresses over time. And of course, this can cause increased tendon thickness on imaging. With regards to the calcaneus, we often see bone marrow edema on MR imaging in these patients due to a cumulative and tractional irritation from the inelastic Achilles on the insertional aspect and posterior superior aspect of the calcaneus. Of course, as mentioned previously, there is very often, particularly in more chronic cases in the older patients, a painful posterior osteophyte, which occurs via cumulative and chronic mechanical loading. This is often bilateral, but in my experience, and I think this mirrors the literature, one case is typically, one side is particularly more symptomatic than the other, and in most cases, in my experience, patients who required surgery required it unilaterally. Most patients do not go down the same path with both extremities. So patients who have insertional Achilles tendinopathy or tendinosis typically acquire that diagnosis based primarily on physical exam and a history. These patients have pain at the distal 2 centimeters of the Achilles, as is pictured to the right. They often have pain within the retrocalcaneal bursa. They have pain at the posterior aspect of the heel because of the osteophyte, and they may, upon examination, have exquisite pain just anterior and inferior to the retrocalcaneal bursa due to the marrow edema that we see on MR studies. I personally see a high rate of equinus contracture in these patients when I examine them. With regards to imaging, we all, I think, routinely obtain weight-bearing foot or ankle films, or both in these patients. Prototypical of these patients is that pathognomonic posterior osteophyte, and most of the time a large bursal projection. Typically an MR is not absolutely required, but typically garnered and shows T2 increased signal within the insertion of the Achilles on the calcaneus. We often see, as we see here, pictured above, retrocalcaneal bursitis and tractional edema within the posterior superior aspect of the calcaneus. And I like to explain to patients that when they're younger, their Achilles is much like a rubber band and has a lot of elastic properties and is able to recoil quickly and proficiently. But as we get older, the Achilles becomes stiffer and more contracted, and so it tends to yank and pull on the back of the heel in these more chronic cases, compared to a gentle prodding by comparative measures in patients who don't have any pathology. And so over time, the Achilles, which initiates each step, goes from something that gently influences or prods or pulls the calcaneus towards the head, and the bone tolerates that favorably, but over time, as things tighten up, there's more of a yanking effect, which causes these changes on MRI, and I think also causes what we see on the bottom slide there, which is just a general thickening, sclerotic thickening of the posterior planar aspect of the calcaneus, where the tendo-Achilles and the plantar fascial ligament come to a confluence. I think there is a tug of war that ensues between the posterior compartment and the plantar fascial ligament in these patients, particularly upon startup after a period of rest, which over time causes these compensatory changes that we see both on MR and plain films. I think a conservative treatment protocol of 3 to 6 months is reasonable in these patients. These chronic cases or degenerative cases are much more difficult to treat, and it's been suggested several times in the literature, and I would agree with these based on my own experiences, that less than 50% of the time these patients with these more chronic cases avoid surgery. But initially, an attempt at non-operative treatment is preferable, and this typically entails physiotherapy, night splinting, non-steroidal anti-inflammatories, shoe and activity modifications. In the younger population whom develop this because of overuse, these patients need to shut things down. Anti-inflammatories and rest help quite a bit. It just makes sense that these patients whom perhaps run 5 miles 3 times a week are never going to get much better unless they lay off the running. In the older, more sedentary group, the activity modifications and the non-steroidal anti-inflammatory tactics are generally far less successful. I've put a question mark next to corticosteroid injection because historically it's shied upon or shied away from, but I have to say and admit that in my practice, I don't do this regularly, but I certainly have done it in situations where patients were just absolutely miserable. These tended to be older patients with more chronic changes, more sedentary patients, and I essentially make a contract with them. I will give them the injection, but they have to agree to go into a walking cast, whether that's a fiberglass cast with a boot on the end of it or a cam walker, but generally for 2 to 3 weeks. And fortunately, knock on wood, I have had no adverse effects or ruptures that I know of anyways from this. The hallmark of any non-operative treatment protocol for insertional Achilles tendinopathy, I think, has to center around heavy load eccentric stretching or Alfred's regimen. The downside, I tell patients, is that you need to be very religious about doing these, and you need to do about 100 to 150 repetitions per day, and it typically will take 2 to 3 months of doing this to see favorable results. So what's pictured here is a little bit different from Alfredson's regimen, or the way that I have patients stretch. This is more of a generic heavy load eccentric stretch in my opinion. So in my patients, I have them go up on their tippy toes, but on the way down, they lift the asymptomatic foot up. If they do have the disease bilaterally, they can certainly do this bilaterally as the heel goes down towards the floor, but if it's unilateral, I have them pick the asymptomatic side up as they go down. There is fairly favorable results in the literature. Hansen et al. In his paper described a pain reduction using a VAS scale of just about 50% after 3 to 4 months of stretching. Now, there is in the literature descriptions of treatments using extracorporeal shockwave therapy, prolotherapy, and within the last handful of years or so, PRP and bone marrow aspirate concentrate, which I'm not going to go into too much here because there's not a ton of literature specifically regarding orthobiologics and insertional Achilles tendinosis. So in my practice, when patients fail, or if they fail that initial non-operative treatment tier, then I move them up to the second tier, which in my hands is an intermediary between the stretching, the activity modifications, and the aforementioned, and a full-blown open reconstruction. with the use of a gastrocnemius recession. I found that in my practice, the vast majority of these patients are tight and they have contracture of either their gastroc and their soleus or their gastroc. Of course, in these particular patients, we're likely going to shy away from any kind of a Achilles tendon lengthening. So even if they're have shown to have signs of gastric soleal contracture as opposed to isolated gastroc contracture, I'm going to do a gastroc recession. And I put plus or minus biologics in here because it has been described and it is utilized, but there's no retrospective studies that I saw that looked at treatment arms with gastrocnemius recession alone versus gastroc recession with biologics. It certainly is a less invasive approach than the fully open approach, with obviously a shorter recovery time and less morbidity. I tell patients and have patients agree to the acknowledgement if we are going to undertake a full-blown open reconstruction, that the recovery is protracted and it can take 9 to 12 months for patients to reach the mountaintop, if you will. And so it's definitely more of a marathon than a sprint. With regards to the gastrocnemius recession, however, the literature is fairly favorable, and there's really no major complications other than plantar flexion weakness and push-off strength. So this is probably not good for athletes, but I would argue that most patients who have insertional Achilles tendinosis who are athletes and belong to that younger tier of patients don't get to this second tier. So if a patient has failed conservative treatment measures and they wish to pursue a surgical option, and most importantly, they really understand that the surgery will require 9 to 12 months of recovery, and there's going to be some ups and downs and periods where they love me and other times when they hate me and are wondering why they did this, then we will schedule them for surgery. A surgical video is to follow, but in my hands I use what I think most use, which is the central splitting incisional approach, which involves an aggressive ostectomy to both the posterior and superior aspects of the calcaneus. In my hands, I perform a complete retrocalcaneal bursectomy, and I enucleate or debride the non-viable degenerative portion of the Achilles insertion away. And it's at that point that I determine whether or not a patient needs augmentation, which in my hands is an FHL transfer, which is pictured here. And I just judge this intraoperatively based on how much mechanical strength I think has been lost directly secondary to the amount of excised or enucleated tendon. For heavier or more active patients, I won't hesitate to do the FHL transfer. It's fast and easy. I usually can do it in 5 to 10 minutes or so. I do counsel patients ahead of time that this may be necessary and that they will have some weakness at their great toe joint with plantar flexion. And once this is all done, I perform a double row repair like most surgeons do. I try and be exceedingly gentle with regards to handling and manipulation of the skin. We know how easy it is to develop a wound in the posterior aspect of the lower leg, and what a nightmare it can be, so I try and do everything I can to avoid that. I do use Venco powder and close with a vertical mattress with 3/0 nylon. You never want to use staples back here. I put patients into a bulky, well-padded sterile dressing with a posterior splint, and typically DC the post-op dressings at 2 weeks, and put patients into a cam walker at that point in time, and remove the sutures 1 week later at 3 weeks. So after 2 weeks, they can start to quickly take showers, but the sutures are still in place. And this obviously depends on the wound looking healthy, and I have a reliable patient. So patients are non-weight bearing for 4 weeks. Then at 4 weeks, I start a graduated weight bearing program and a cam walker with a set of heel lifts. As they start to walk in the cam walker, after 2 weeks, I reduce the heel lift by 50%. I use 2 heel lifts. I just take one of them out at 2 weeks. At 8 weeks, they're back to shoes, but back to having 2 heel lifts. So they go through 2 heel lifts while they're in the cam walker, then they go through 2 heel lifts as they are introduced back into their normal shoes. And so I decrease the heel lift in the shoe by 50% after 2 weeks, such that in total, they're back in their conventional shoes most times without any kind of augmentation or heel lift or so on and so forth at 12 weeks. So in summary, this is a fairly common condition. I probably see 2 to 3 new patients with this each month in my clinic. It generally affects 2 different groups of patients. Who tend to be either young athletes with acute changes or older, overweight, and more sedentary patients with more chronic degenerative changes. Typically, activity modifications, non-steroidal anti-inflammatories, and anti-inflammatory tactics work reliably well with younger people. However, non-operative treatment is commonly unsuccessful in the older subset of patients. The disease, if you will, is characterized by a posterior heel spur, a bursal projection that's notable on X-ray and MRI, and frequently retrocalcaneal bursitis. Heavy load eccentric stretching, or Alfredson's protocol or regimen, is the hallmark of non-operative care. And surgery is reliable, but the recovery is protracted. Stay tuned for a surgical video, which should be forthcoming, and thanks for watching.